Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Gregory Steiner. Dr. Steiner is a periodontist and has been involved in the development of improved bone grafting since 2006. He heads up a corporation called Steiner Bio, and we have a fascinating discussion about bone grafting, some of the fallacies of cadaveric bone grafting. We get into bone physiology and also talk about osteoporosis. I think anybody who has dealt with bone or deals with bone will be interested in this discussion. So please enjoy this conversation that I had with Dr. Gregory Steiner. All right, I'm here with Dr. Greg Steiner, and I first was introduced to his work when he gave a lecture back at in May of 2023 for Dr. Schallenberger's Ozone Therapy Conference, and I was tremendously impressed with what you presented there, and I'm anxious to talk about bone grafting. It's something that I think our audience will have a great interest. So thanks for taking the time, Dr. Steiner, to come on the show this afternoon.
Well, thank you very much for inviting me. It's a pleasure to be here. I'm always willing and eager to share anything I can share with you and your community as far as the one thing I know about, which is bone and bone grafting.
Let's talk about your journey into the bone grafting world and why you were compelled and ultimately develop this level of expertise in bone grafting.
Well, basically my training is in dentistry, dental school. Then I went into periodontics after dental school, specialty training, and I loved my profession. I just couldn't get enough of it. I loved doing it. I loved studying it. I loved treating patients. But the problem I had is that as the years wore on, I realized that there weren't any improvements in the therapy that I was providing my patients. There were no advancements in the type of things that we were doing. And I was sitting there simply regurgitating the same things that I learned in school, and there was nothing new on the horizon. And that I dealt with that for about 5 years in practice and thought that, well, maybe I was just so well trained that I already knew everything that was coming out. And but after about another 5 years, I realized there's never going to be anything new. I was going to spend the rest of my career saying the same things and doing the exact same therapy. And I just could not do that. So I quit.
Okay.
And I didn't want to do that. I didn't want to throw away, all these years of education. And I didn't actually have anything to directly fall back on. But I knew I would just be an extremely unhappy clinician, hating my job, if I never saw improvement in the type of things that I was doing and never saw a change. And so I quit. Moved the family to Hawaii and started looking around for what else I wanted to do with my life, and actually got into doing some epidemiology and cancer research and had some interesting findings there. In fact, if anybody's interested, I would encourage them to look at the research that's been done on a product called kava. It's an actually root, and it's been found to greatly reduce cancer rates in the South Pacific Islands. And so I did work in that area, published a paper, And then I got a call from a colleague that was disabled, and he needed somebody to keep his practice alive
Okay.
and till he could sell it.
Right.
And so I told him, okay, I'll do that. I'll help you. I'll keep your practice alive till you can sell it. And so what I decided to do is that was about 5 years after I quit. So I went back and reviewed all the research that was done in those 5 years to make sure I was current. And what I found is exactly the same thing I knew what I would find, is there was nothing new. And so when I went back to start treating patients again, I just decided, nobody's coming up with anything new, so it's going to have to be me. And so I went back and I started developing new techniques, looking at the products that were out there, seeing the shortcomings. That's how I got into developing bone grafts. And that's why I'm here today, is because what was being used at the time simply wasn't working and wasn't acceptable. And I wanted to make something that was acceptable in my hands for treating my patients. And that's why Steiner Bio came into existence.
Now, was that primarily the failure of cadaver bone grafts? Is that what you're, okay.
Yes. The cadaver bone grafts, nothing that dentists are taught today about cadaver bone grafts is true. And you might think that's stunning, but it is stunning. And it is stunning that they're simply told what they're supposed to believe. And they're told, and it's told so many times, and so many of them believe it, they actually accept it as factual, but it's all wrong and it's all actually inaccurate. And so it was the fact that I was actually using cadaver bone grafts, 20 years ago before I started this. And I just looked at it and I says, this is really a terrible bone graft, and I don't like what it's doing. And so not only did I decide to produce a different type of bone graft that actually was science-based and created in a laboratory, but I also looked at what the problems were with the other types of bone grafts on the market, mainly cadaver bone grafts. And so I've done a lot of research on how they work in the body, what they do to the body, what damage they do to the body. And basically, look at it this way. If you have a kidney or a liver transplant, there is meticulous effort put into making sure that that's a good match from the donor to the host.
Mm-hmm.
And it's the responsibility of the transplant team to make sure that that match is going to be successful. Correct. Well, in a bone graft, you're using a cadaver bone graft, there's no matching. There's no effort to see if the bone graft is going to work or how it's going to react. And so consequently, the results are extremely poor because there's not even any effort to make any match. Even if they did match it, the results would be the same. The bone graft would produce a scar type of tissue, and it would never turn into normal bone. And so basically, that type of information was the knowledge that we developed over time. And needless to say, it was not well received by the profession when I was starting to talk about this. But I had the advantage of the fact that 20 years ago, I started doing nothing but studying bone and bone grafts full-time. I would work part-time, a few days a month, pay the bills, but all I did was study bone and bone grafts. And the problem in dentistry is that a dentist never even gets a lecture on bone.
Okay. They
never have anybody talking to them about what bone is. And so it's just a void of misinformation. And so dentists get very little information on bone and virtually none on bone grafts. And so when I had dedicated my life to studying this, the information I was finding was not well received at all. And so, when I started telling people about what my findings are 15 years ago, oh, they'd be furious. They would cuss at me. They would tell me I have no right to say these things. The danger to the profession. That was 15 years ago. 10 years ago, they went quiet. Okay. Now they're turning to me because they're realizing that what I've been saying all along is becoming factual. So there's been that switch. So when you talk about going up against academia and the established norms that are in academia, the problem is that if you are in a certain area of academia, whatever your specialty is, it could be periodontics, it could be podiatry. they all believe the same things.
Mm-hmm.
They all teach the same things.
Right.
They don't accept anything outside that norm because they all know the answers, right?
Right.
And so when you go against the norm, it's not well received.
No, I know that for a fact myself. But one of the premises of this show is I want to destroy some ridiculous dogma along the way. And let's talk about, because it sounds like there's a lot of dogma about cadaveric bone grafts that you said not only is wrong, but it's still perpetuated in the curricula of these different institutions.
Oh yeah, it's absolutely stunning. And it's an unusual thing because in the United States, cadaver bone grafts is the only bone graft that's taught in all of the universities. There is nothing else taught. That's not the truth in Europe. In Europe, there's a lot of hesitancy for the population to use cadaver bone grafts. So they're not the 100% answer.
Right.
And so there's a variety of bone grafts, and they're very open to different types of bone grafts. In Asia, many of those Asian cultures absolutely refuse to have cadaver bone graft put in their body. So it's only the United States that has this monolithic concept of what a bone graft should be for their patients. And so, but that's where I am, and so that's what I have to deal with. But basically, what a dentist is taught when they're in any type of level of training, whether it's a regular dentist or they're in specialty training with periodontics or oral surgery, they're simply taught you use a human tissue, use cadaver bone grafts. You take the cadaver bone graft, you put it in your patient, it stimulates bone to grow. And as it's stimulating bone to grow, the bone fills in the area that you want it to fill in. It turns into nice, healthy, vital bone. And then the body resorbs it all, and it all goes away, and you're left with nothing but normal, healthy, vital bone. And everything I told you is completely wrong. And there is not one published paper that supports anything I just told you, but that's the entire profession believes. And when you review the science with them, you sit down and say, okay, let's go over these issues and let's study each one of them one by one. You share with me the science that supports your position. I'll share you the science that supports mine. Well, they're up against the wall because they got nothing to support it, and they get angry, and then they won't talk to you anymore. Right. I've been through it many times.
Well, that's kind of par for the course, isn't it? When someone doesn't have an answer to, a very strongly proffered question based on science, then they just have to attack the messenger. And
it's just routine, and I'm accustomed to it.
It's almost reflexive. It's almost like, there's no thought whatsoever. It's just a reflex. It just, but I think this would be pretty hard to argue if you have the actual histology slides there that you showed in your lecture when I was in the audience. It's kind of hard to argue with real histology, isn't it?
There's a concept, and basically you probably heard of this concept. It's called a paradigm, right?
Right.
Okay, so cadaver bone grafts in the United States is the paradigm. That's what everybody teaches and believes.
Right.
Okay. Well, a very smart man, and I may have brought this up in my lecture, a physicist by Max Planck, and most anybody who studied science knows that Max Planck is one of the most brilliant men that ever lived. And what he said is that if you are interested in changing people's minds by reasoning with them and showing them that they are not correct and what they believe is not accurate, you will never accomplish it. And you simply have to wait for them to die for a new generation to come along.
Yep.
Which is, and when I read that quote, and he's talking about a paradigm, which I'm dealing with in dentistry, it's the actual truth. They won't accept the science that's in front of them. And, it's human nature. It's not that they're bad people. None of these people are bad. They're all really good people.
Right.
But they've been taught, and everybody believes the same thing. And so when they're challenged, they just cannot accept that they're wrong. And again, but the thing is though, like I showed you the histology and the science. And as I also, you may have known that I actually criticize a lot of the research that's out there because it's so blatantly biased, and I point out the deficiencies in it. And it is having a serious and significant effect. That letter that I sent to the new editor that you mentioned a while ago,
right,
of the Journal of Periodontology, well,
yeah.
she just took over a couple months ago.
Okay.
And the recent issue of that journal has been completely revised according to the recommendations that I made to her. So they're
That's
listening.
very good.
I was
really good.
shocked.
Yeah.
I didn't expect it.
Yeah.
I was shocked.
Well, there are certain academics that have more of an open mind and are more, I think, would lean more to the evolutionary process of evidence-based medicine. I know evidence-based medicine is a term that is fraught with difficulty in and of itself. A lot of times that's a fence to keep an insurance company from paying the provider, the clinician, because it's not evidence-based. But when you look at some of the evidence-based, real evidence-based stuff, are histology, are objective findings, not subjective findings. And that, I would think with bone grafting, it's pretty hard to argue with a histology slide. I mean,
well, you have to look at it this way. Like I told you, dentists get no training in bone.
okay.
And you're a podiatrist, you spend a lot more time with bone than dentists do by far. But when I show dentists histology, it may be the first time they've ever looked at a picture of bone. And so they're taking my word for it, which they may or may not want to. So it's a field that is really, you really have to have a deep amount of education to be able to look at that slide and understanding what you're looking at. Right. And because it is a very complicated thing. And in my mind, I don't know, you're in podiatry, you deal with bones all the time, but in people think of bone as that's sort of a simple thing, it's just a hard object.
Right.
I think bone is probably the most complex organ in the whole human body. You think of all that it does. You think not only does it support us, gives us form, not only does that, it supplies all of our immune system. It supplies all of our blood cells. Right. This is one of the most complicated organs in the entire body. And because of that, you just can't take a weekend course and really understand what you're dealing with. And it doesn't give you the depth of understanding. But, there are a lot of people in my profession and in all professions that are dedicated to understanding what's happening. And we have seen a big change in our profession because our profession is definitely moving away from cadaver and into science-based bone grafting. And and the reason I know that firsthand is because we see it on how it affects our sales, because we're seeing the change. And we've been working at it a long time, and it's finally getting to that point.
Well, I can tell you for sure that the same paradigm exists in orthopedics and podiatry as well, is that, bone is this pseudo inanimate tissue that you can cut it, screw it, move it, plate it, whatever you want to do, and it's all going to be good. And that is so far from the truth that, but it's almost like this just keeps getting perpetuated from year after year after year in the training. And one of the first times I realized the nuances of bone was when I crossed paths with a guy named Wolfgang Schaden. I don't know if you've ever heard of him, but very big in using extracorporeal shockwave therapy to treat non-unions of the tibia. And they would shock the contralateral leg and show healing. And I mean, this guy was such an expert in bone. He could tell you the interosseous pressure of all the different bones in the entire body. I mean, he was really, and I'm thinking, wow, this guy has dedicated his life to this stuff that we just screw it, plate it, move it. It'll do whatever you want, So it's kind of like that ignorance is just, you're so ignorant, you don't even have any conceptualization of how complex it really is. But like you talk about it, the immune system in and of itself is a whole different thing. You know, I mean, what happens if you kill all the marrow in a patient? They don't live very long.
No, and the immune system is all based in our bones, and so it is and that's one of the things I love about studying it, because I know I will spend the rest of my life studying something that I'll never fully understand, and that's the good part of it.
Well, the more you study, the more you'll know that there's that much more you don't understand.
Ain't the truth?
Yeah, right. I mean, I feel like that's the same way. I specialize in peripheral nerve, and the more I study, the more I get humbled, and you almost get to a point where there's just so much you realize that you don't know. It's almost paralyzing in a way. I guess it kind of goes to that paralysis by analysis thing, you know, sometimes, you know, but I think that's what happens. So what's going on with cadaver bone? I mean, you make the point that it doesn't really create the bone that it's perceived to create. It ends up as sclerotic bone. Tissues have difficult times growing over it. Give me some more insight on that.
Well, what's interesting is that you understand it very well. I wish my audiences would all be picking up on it like you are. But the interesting thing is there's a difference between what dentistry does with bone grafts and what orthopedics does with bone grafts. Because when orthopedic medicine, in my experience and from what I see, when they place a cadaver bone graft, they're basically using it as a filler. It's filling a defect, but it's not designed to be the structural support, right?
Right.
And it's mainly just to fill a hole and let the bone heal around it, and that's all well and good. But in dentistry, it's a very big difference, because what happens in dentistry is that you'll take out a tooth, you'll put in a cadaver bone graft, and then you put an implant in that site. And so all of a sudden, it's not just a filler, it's actually providing support, and it has to handle load. And when you put load on the cadaver bone graft, that's when it fails.
Right.
So basically, in orthopedic medicine, they don't rely upon simple cadaver bone grafts to support your leg. They're going to put braces and bars and struts like that, and they might pack a little cadaver bone graft around it. So there's a big difference. In dentistry, the cadaver bone grafts fail a lot more frequently because they're relied upon to support the load of the dental implant. And so that's a difference. But there's also another interesting thing, is that, believe it or not, bone grafting and bone regeneration is more advanced in the dental field than it is in the orthopedic field.
I don't doubt that at all.
I'll explain to you why that is.
Yes, please do.
Well, for instance, when you do an orthopedic surgical procedure, and no matter where it is in the body, and you put a bone graft in there, well, you can't go open that patient up to look at it and analyze it and see what it's doing. That's a human being. You can't do that.
Right.
That's harmful. Well, in my situation, I will take out a tooth. I'll put my bone graft in the extraction socket. I'll let it heal, and then I'm going to put an implant in there, but I'm opening the tissue. I'm taking a core sample. I'm analyzing every single bone graft that I do. So I can do constant research on all these samples that I get out of human beings that orthopedics can't do. Right. So a lot of the bone graft surgery and a lot of the bone graft understanding is actually happening in dentistry simply because we have the availability to harvest our grafting sites.
Well, so, and one of the things, I don't know if you mentioned this at your lecture or I picked it up from another lecture, but I really had never thought about it in this realm, is that, you know, we have, like, when we do something with a bone, you made the great point that we close it up, we have a soft tissue envelope, except when we use maybe an external fixator or, you know, a percutaneous pin or something like that. But in the jaw, or in, you know, both the mandible and the maxilla, the bone is essentially exposed with this percutaneous thing called a tooth, that it's not sequestered away. And it's kind of amazing, really, that we have this oral microbiome, and we have this, it's not a sealed container from where the tooth is going into the bone, whether it's
Not at all. I mean,
yeah.
as far as bacteria and infection and all that stuff, back in the day, many people sort of poo-pooed the concept that, something in one part of the body can affect the other part of the body. Oh, that doesn't make any sense. But there's, as you know, and I'm sure you fully understand, we're all connected, and anything that's going on in one part of the body can easily affect some other part of the body. And in dentistry, the bacteria that's present in the mouth and in and around diseased teeth does gain access into the rest of the body. And for instance, in orthopedics, a very big thing. Most orthopedic surgeons are going to do any significantly invasive orthopedic surgery will require that their patients go see their dentist and get the dental disease taken care of, because they don't want a tooth extracted a month after they've done their orthopedic surgery, and that bacteria winds up in their surgical site.
Exactly.
And so, we're all connected, and it's very critical that, we maintain the health of our entire body, because it affects everything else.
Now, when you were putting in for periodontics, when you were putting in the cadaver grafts, was it more susceptible to developing an osteomyelitis, or didn't see that? Or why isn't there? Well, I guess the question would be, how often is there a development of an infection in the bone graft after you place it? And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
Well, that's a very interesting question. Now, in normal instances, infections in the jaw, almost never, I've never seen one, put it that way, never develop into osteomyelitis. The infection, and we're talking swelling, draining pus, horrible infections.
Wow.
Where if those infections were anyplace else in the skeleton, the patient would be in ICU struggling to live.
Right.
But the mouth is unique. And in fact, even the structure of the maxilla and the mandible, they're different from the rest of the skeleton. In the maxilla and the mandible, we don't have marrow. There's no bone marrow in those jaws, even though dentists believe there is, but there's none. There's actually something called stroma, which is, it has no bone, blood producing cells in it at all. It's a very simple tissue. And I believe the jaws are different from the rest of the body, because I believe that's what allows it to sort of compartmentalize the infections that are constantly present in people's mouths. People have tremendous infections, but they don't spread throughout the body. They don't develop into osteomyelitis. They're compartmentalized, because I think that's how the jaws had evolved. They've evolved this ability to handle these infections without it. Because you think before modern medicine, everybody had teeth problem, everybody were losing teeth. And if every one of those persons developed osteomyelitis of the jaw, they'd be dead.
Right.
And because there's no way to, back in the day, how to treat it. And so the body developed its own mechanisms for dealing with oral infections that are somewhat different from the rest of the body.
Yeah, because you would think, you know, you have this incredible pot of different bacteria swimming around. What you put in there, it's not like you can put an antiseptic dressing over that spot while it, you know what I mean? It's still exposed.
Oh yeah. Well,
Yeah.
that's one of my biggest complaints is that of dentistry, because in medicine, and this is how I talk to my patients. I say in medicine, you know, even the most minor wound, even the simplest procedure that is done to you, your medical health professionals are going to clean it, close it, and dress it. They're never letting you walk out with an open wound. But in dentistry, what do dentists do? They take these pliers and they grab that tooth and they put tremendous force on that tooth. They pull it out of the body. And here we got this big, huge gaping wound in the jaw that the patient walks out the door with.
Right.
And it blows my mind because terrible things happen. The jaw collapses, you get dry sockets, you got bacteria everywhere, and dentists don't think anything of it. And so it's one of my biggest pushes is that if you have a tooth extraction and you want to protect your health and your jaw, you need to do what medicine does. You need to clean it, close it, and dress it. So that wound is protected when you walk out the door. And one of the things that we use is we close it with a bone graft and we cover it with a membrane similar to a bandage. But I believe strongly that anybody that's at all interested in good health should never have a tooth extracted and walk out the door with some big gaping wound in their jaw. Right. And that's one of my main complaints about dentistry is that it's barbaric in that respect.
Now, what about topical ozone? Is that being used more from before you prep the site to maybe as an antiseptic?
It's used afterwards. After the tooth is removed, it's usually applied to the area to try to control any residual infection that might be left behind.
Okay.
And it's also a problem in dentistry because you know, I don't know you know much about it, but there's some legal issues with the application of ozone. And many of the early users of ozone had significant problems because other dentists are saying you shouldn't be doing this to patients without justification. And so the use of ozone is becoming much and more common for the treatment of residual infections.
Right, right. Well, ozone's pretty used in Europe on the day-to-day, but it's still kind of frowned upon here in the United States, but that's another discussion. So aside from the cadaver bone graft just not incorporating in the jaw and then subsequently holding the implant, did you see any changes as far as rate of healing as you morphed into the more modern bone graft that we're going to talk about in a little bit?
Can you repeat that again? I think I missed a few words. What was that?
Okay. All right. So basically what I'm saying is that we've already declared, or you've already declared, that the cadaveric bone graft doesn't really incorporate. It becomes a scaffold. It's sclerotic. It doesn't adjust from a histological standpoint like you would ideally want it, so that your implant would hold and handle those load forces that you were talking about. I guess my point was, from a healing standpoint, was there a difference in your bone graft as far as how long after you grafted it until you could put the implant into it versus the old technology?
Oh, yes, there's a tremendous difference. First off, nothing should be put in bone that doesn't completely goes away. You should never use any type of bone graft that leaves behind any residual material, because that's not real bone anymore, right? I mean, if there's stuff stuck in it,
right, it's
not going to be normal bone, and it's pretty much all going to be sclerotic. So even if you use a synthetic bone graft that is non-resorbable and doesn't go away, it isn't taken away by the body, that is not normal, healthy, vital bone, and you're going to have problems with it. Now, it may not be pathologic, so you know, it may just be very dense and it may not support your implant well, but it's only the cadaver bone grafts that actually produce pathologic tissue that's called sclerotic bone that that is the biggest problem. So it's the cadaver bone grafts form as a result of this tremendous inflammation that they create. And the mineralization, well, I can explain it to you really simple. If you cut yourself and the wound is slow to heal, you'll get a scar. Well, what is that scar? It's just dense collagen is all it is. The scar is going to be there forever. It's never going to go away, and it's never going to change. Well, the same exact thing happens inside the bone because the cadaver bone graft creates an inflammatory process. And it's the inflammation that produces this dense collagen in that scar that you have.
Okay.
So it produces a dense collagen, but because it's in the bone, it mineralizes. So you basically have an area of scar tissue that is mineralized in bone, where it's just normal collagen on your skin. And the only time you ever get scar tissue formation is when you don't transition from an initial insult. You need to go from acute inflammation, which is the initial insult, to regeneration. If you ever have a wound that goes from acute inflammation to chronic inflammation, you're going to get a scar.
Right.
So you need to avoid the chronic inflammation in order to have proper healing. One of the areas of medicine that I'm constantly amazed at is people that do the facial surgery for what's it called? It's a surgical procedure to remove cancer, where they cut out the cancer and they slice it and they look at it. What's that?
Mohs surgery.
Mohs, that's what I'm saying. Yeah.
Right.
I'm amazed because those people can cut out a big part of your face and not leave a mark.
Yeah.
And the reason they do that is because they're so fine with their incisions that the wound immediately goes from the acute trauma to regeneration and no scar tissue. It's an amazing, I'm amazed at those guys because I know myself, I've had a number of them and I might look scarred, but it's actually hard to see from the Mohs that I've had done. And so if you avoid chronic inflammation, you'll avoid scarring. That's how simple it is. And various bone grafts that cause chronic inflammation, they're never going to produce normal tissue. And I don't know if that answered your question. I got off to a little bit of tangent.
Yeah, no, I think that answered the question. It gave me a little bit more insight. So what is the complication rate with cadaveric bone for the periodontic implants? What's the, for lack of a better term, the non-union rate, or when that post or the implant just doesn't, it just doesn't snug in there like it's supposed to because the graft doesn't have the ability to sequester it like it should?
Unknown.
Okay. What's your gut instinct?
Oh, I know it's a much higher failure rate. Well, there's a couple things. There was a couple studies that are out on short-term implant failure. And these studies, I probably mentioned it, and these studies are very well done studies because huge healthcare institutions are constantly doing statistical analysis on what works and what doesn't.
Right.
Mayo Clinic, Kaiser, they all have a bevy of statisticians because they want to know the cheapest way and the best way to do the treatment. And so they do statistical analysis on everything. Well, it just so happens in two big major institutions, Mayo Clinic being one of them, they did that for dental implant placement. They looked at what works and what doesn't. And I mean, when they look at it, they look at, what was the room temperature when it was placed? How much experience did this? I mean, every variable that you can imagine they look at. And they only found one thing that resulted in early implant loss, which is in the first year. There was only one thing that statistically resulted in that, and that was putting an implant in a site grafted with a cadaver bone graft. Nothing else caused it. Okay. But we go from that and we go say, but then you say, well, what about long-term effects? What is the long-term effects of putting an implant in a site grafted with a cadaver bone graft? Now, I might tell you that procedure is done thousands of times a day in the United States. It's what people do when they take out a tooth. They put in a cadaver bone graft, and it's done in dental offices across the United States a few thousand times a day at least. And the long-term success rate has never been studied.
Interesting. Okay.
We have no scientific basis for it. Personally, I believe it's been done. but they didn't like the results and they didn't publish it. That's my personal opinion. But for our profession to talk all the time about science-based dentistry or evidence-based dentistry, and then do this procedure that they have no statistical support for and no science to back it up, is ridiculous. And they shouldn't be doing it with no science base for doing it. And I do believe when those studies, I know they've been done, they just haven't been published. But when they are published, then we're going to find the real effects of it. And I could go into a great amount of detail that would bore your audience to death. But basically, to be honest with you, for cadaver bone grafts, those studies have not been done. For synthetics, they have been done. Okay. They've been done. And for our products ourselves, what we did is we did a study. It was a 3-year study. We took out the tooth, we put in the bone graft, we put in the implant. Once the crown went on the tooth, when it was in function, we followed 100 people for 3 years, and we had 100% success. That's published. Right. That doesn't exist for cadaver bone grafts. It does exist for ours. There's a couple other synthetics that have published research also. But yes, there is science-based evidence for some bone grafts, but not cadaver bone grafts.
Oh, that's excellent. So let's go into what you guys are doing, the difference between your grafts, and now that we've relegated cadaver to the, the persona non grata of bone grafting, let's talk about what you've done and your innovations.
Well, when I first looked at bone grafts as a problem, I realized that number one, I didn't like the way the bone looked. I just thought this is not normal. And at that time, I was just as ignorant as everybody else that never had any bone education. And I just said, this doesn't look normal and I don't like it. So I'm just going to try to develop a bone graft that produces normal bone. So the goals were 2 things. One, I wanted a bone graft that stimulated the formation of bone so it healed quicker and better. And I wanted something that totally disappeared and removed from the body, that there's nothing residual. Nothing should ever be residual in a patient's body that you don't have to have there. I mean, if you've got a piece of metal that's holding your body apart together, that has to be there, but there shouldn't be anything else there that can cause problems down the road. So those were our 2 goals, and that's what we accomplished. And we're basically the only bone graft on the market that we're allowed to claim that we actually stimulate bone formation, and that's in both medicine and dentistry. And we're the only bone graft that actually is bone grafts at the FDA are defined as a device. Like you use a metal plate, the FDA says this is a device. A bone graft, they define it as a device because devices typically don't have physiologic effects. They're there to solve a problem, pacemaker or what have you. But then you have the pharmaceutical division, which is for the drugs. But our bone graft contains a drug, and it's that drug that stimulates the formation of bone. And we're the only one on the market that has that type of graft.
Explain that, or if you're able to share that, what is the drug that you combine it with, and give us a little insight into the physiology of that, if you could.
Well, it is a small chain organic compound.
Okay.
And it is already in the body.
All right.
And so there is not one thing in our bone graft that isn't already present in our patients. And that's why we can easily say you can't have an allergic reaction, you can't have an adverse event, because everything's already there. And what we found is this molecule is critical for bone formation. Without this molecule, bone will not form. Okay? Okay. And the thing that we found is that in a wound in bone, when there's the physiologic process of what's going on in the bone doesn't allow this molecule to get to the site. Okay. Okay. So that's why bone grafts are never that fully successful, because they run out of this molecule. They're done, and they can't form any more bone because they don't have this molecule. So our innovation and our patent is to, because of that discovery and of that molecule, we put it in our bone grafts so it never runs out of it. In essence, the cells never run out of gas, so to speak. So they continue to form bone, and that's how our bone graft works. And that's why, people think of drugs as a problem with a lot of complications. Yeah, they are. but not if it's natural to the body.
Right. Yeah, no, there's a lot of merit to that. So the graft that you all have, is it in a flowable form, or is it kind of a matrix? How is that?
Well, yeah, the graft that actually stimulates the bone formation it's sort of mostly like a putty. Okay, because a putty you can form shape and put into place and it'll stay put. So that's the one that stimulates the bone growth. And you asked earlier about, what's the difference between your bone grafts and how long it takes to put an implant in and how fast it grows and all that stuff. Well, traditionally in the past, you'd take out a tooth, you'd put in a cadaver bone graft, and maybe 3 to 6, 8 months later, you put in your implant, and then maybe 4 or 5 months later that you put on a crown. So you're looking at 6 months to a year before you get a tooth to chew with.
Right.
Well, with our bone graft, because we stimulate bone formation, we put an implant in 1 month after the tooth is extracted.
Wow.
And in essence, what we're doing with that is that because our bone graft stimulates bone formation, we put the implant in while the socket is healing.
Okay.
Everybody else puts the implant in after the socket has fully mineralized with bone. And nobody's come up with the concept of maybe I should put it in earlier, because that's when the cells are rapidly growing. That's when the bone is forming. And so that's why we have what we call a 1 month early implant placement, because that's the time when the bone is growing the fastest. And those are the cells that attach to the implant. So the same cells that make the bone are the same cells that bond to the implant. And so put your implant in when you got the majority of those cells are active, because once bone fully forms, those cells go to sleep. And you got to jar them awake if you want them to get active again. So our early implant is one of the biggest innovations for our materials.
So that reminds me of Wolff's Law, that bones react to the stresses that are put upon them, for lack of a better way to put it.
Mm-hmm.
Is there some play because you're able to implant this quicker while it is still, going through its, let's call it a consolidation or whatever you want to call it? Is there some benefit to having actually some stress put on that tooth that accelerates it? From
actually,
physical...
it's opposite. You can't put load on it during that time, because if the implant isn't stable,
right,
if there's any movement, the cells won't bond to it.
Okay.
It's like you break a bone. Well, you put it in a cast because you need to stabilize it for it to bond.
Right.
Same thing with an implant.
Okay.
So we put it in and we sort of isolate it from the body. We don't put a crown on it at that point in time. We let it heal for a while.
Okay. I was wondering how you did that, but then I was also wondering if in the normal regenerative process, sometimes, with tendon, for example, we know that when we repair a tendon, we don't really want to put much stress or tension on that repair for the first 28 days. But then at day 28, we want to start putting a little bit of tension on that, because that actually helps the tendon repair itself. It's kind of a, the physiological response to the physical stress.
There is definitely some of that going on, but you have to wait a time period like your 28 days. And that's a pretty good time period, because what we do with when we put these early implants in, we wait 6 weeks before we start the crown process. But the thing is, and the bone will form, but it won't form mature bone. It forms immature bone when it's just growing out and it doesn't have any load. In order for mature bone to form, you have to put load on it, because the body reacts to that load and reorganizes itself. And so, yes, you do want it loaded, but you do have to wait long enough for the implant to be stable.
Gotcha. All right. Very good. Thank you for getting me straight on that. So you mentioned something before we came on air about osteoporosis. Give me a little bit of a primer on that and what you guys are looking at from an osteoporotic standpoint.
Well, osteoporosis is a huge disease. It is. There are a lot of people that actually break bones by walking. Mm-hmm. Normal daily activities, and you see it probably more than I do, because I'm a dentist. People don't come to me with broken jaws, right, because of osteoporosis. But so it's a dramatic, significant disease. But the interesting thing about osteoporosis, it's not really a disease. There's nothing wrong with a person's bones that has even severe osteoporosis. The only problem that exists is that bone is being removed faster than it's being built.
Right.
So in bone, there's two processes. There's a process of growing bone and removing bone.
Right.
And for instance, if you go to the gym and you start lifting weights, you're going to have bone removed, and that bone is going to be replaced in order for your bone to carry a heavy load. So this process of formation and removal is constant in our bodies. It goes on all the time.
Right.
But in osteoporosis, the only thing that goes on is that the removal process is more predominant than the formation process. So over time, bone gets weaker and weaker and weaker. But there's nothing wrong with it. I can go in there and I can take an osteoporotic bone and regenerate that bone perfectly fine, because I'm giving that bone what it needs to regenerate. And that's what we're doing with osteoporosis. And it's mainly focused on hips and joints like that, because the biggest problem in osteoporosis is hip fracture.
Right.
And people will fracture their hips for no reason, or if they fall, if they're elderly, if they fall. And so what we're doing is we're doing more of a preventive type of therapy, where we simply give a patient a little local anesthetic, and we just inject our bone graft into that hip, and we regenerate that bone back to normal, because we're stimulating bone formation. And our bone graft is the only bone graft that actually stimulates bone formation, so we can regenerate bones and prevent osteoporotic fractures.
So I've got to talk to you about, when we finish up recording, I got to talk to you about a patient that's a very interesting patient from an osteoporosis standpoint. But I got to kind of wrap up. How do we get the audience to contact your company and look at some of, I mean, I know I've been to your website. You've got a really some nice videos there, that type of thing. You want to tell the folks how to get a hold of you? And
well, it's very simple. The one thing is, it's just like in your field, everybody has feet and everybody has teeth, and everybody's going to have to deal with dental problems and feet problems at some point in time in their life.
Right.
And people really need to educate themselves, because, you're going into a person's office, and it's just, as well as I, and some people really know what they're doing, and some people are going to get you in trouble. And the best thing that a patient can do for itself is educate themselves, because they can actually educate themselves sometimes better, because they don't walk in with any bias.
Right.
A patient that is listening to what you're telling them is taking your information in and analyzing it. They don't come in with a set of knowledge. And so they're able to sort of weigh the pros and cons of what makes sense to them. And they oftentimes come with a better result, because they don't walk in with a preconceived educational bias. And so what we have on our website is we have a section for patients, because we get calls all the time. Doctor, I'm in this town. I want your product used in my mouth. Who uses your product in our area? Because they've gone to the website, they've looked at what there's available, and they say, I want this in my mouth. So at Steiner Bio, all you have to do is type Steiner Bio into Google. It'll take you to the website, and the first thing you'll see is there's a section for professionals, and there's a section for patients. They can get all the information they need on what's the best thing for taking care of their particular problem.
Fantastic. Dr. Steiner, thank you so much. I could come back and have you probably on another 10 hours just talking about bone physiology, because I find it so fascinating. This tissue that we once thought was just basically a rock that we could cut and move and glue back together. But I appreciate it so much. I think the audience will find this incredibly useful, and thank you for taking the time today.
Well, thank you very much. I'm blessed to be able to study this field. I love it. I'm passionate about it, and I'm happy to talk about it anytime.
Sounds great. This episode is sponsored by Zuckerman Future Technologies. Their REMI laser is a Class 4 laser for professionals. It's different from anything available on the market in that it is a lightweight, 4 pounds, and compact but powerful device. Its large touchscreen makes it easy to use, and the multiple wavelengths, 650, 810, and 980 nanometers, power variables up to 30 watts, and the safety rating make it optimal for many conditions, including the effective and pain-free treatment of soft tissue issues such as plantar fasciitis and Achilles tendinopathy, peripheral neuropathy, neuromas, arthritis, onychomycosis, warts, and more. It is the only laser with FDA 510K approval and insurance coverage. Zuckerman Future Technologies was built to focus on quality products and excellent customer support. When you join the Remy family, you will receive one-on-one training and ongoing support. Zuckerman Future Technologies deals with all aspects of the Remy in-house, and this keeps out the middleman, which allows them to offer this revolutionary device at a 40% reduced price compared to anything that can provide the same or similar results. In addition to this, Zuckerman Future Technologies provide a comprehensive, well-rounded marketing platform that includes customizable brochures and posters, in-office educational videos for your patients, as well as web page and hard copy ad templates. There are currently over 700 Remy users in the United States and Europe, and those numbers are rising every day. Learn more about this fantastic product and join the growing number of professionals who are benefiting from having the Remy in their practice. I personally implemented the Remy laser into our practice about 4 years ago, and I cannot say enough about the utility, versatility, and efficacy that I have seen with this technology. I also can say that of all of the capital equipment that I have purchased, and trust me, it's been a lot over the last 36 years, this is one of the best expenditures I have made. Zuckerman Future Technologies is offering the listeners of the Pot of Inquiry a really great deal. You'll get a $1,000 cart for the Remy laser when you use code 007. That's right, a $1,000 Remy laser cart for just the bona fide Pot of Inquiry spelunkers. You can go to the website, remylaser.com, and use the code 007.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pot of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pot of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.